just going to turn it over to Dr. Enders. It has started. And Dr. Enders, thank you so much for being here today. And we're excited to hear about the topic.
Yeah, thank you so much for having me. So again, my name's Ryan Enders. I'm originally from Wisconsin, but moved to Florida several years ago, and that's where I met my wife and did my medical training. I do general surgery. I've worked at BayCare about a year now. It's going to be a year in a few weeks. I primarily do all of general surgery, but I do like to focus in robotics, and I do have a particular interest in hernias, which is why I was asked to give this talk. So again, I appreciate you inviting me to give this talk, and hopefully it's helpful, and we'll have time at the end for any questions that you may have of me. So this is kind of just the agenda. I'll go over myself a little bit, robotics and the history of robotics in general, and then kind of the program that we have going on here at my hospital. So this is just some about my credentials, where I went to school and did undergrad and medical school, did residency in Pennsylvania. My interests are obviously robotic hernia, and I am trying to develop a complex abdominal wall practice. So I'm in the process of getting training and doing special techniques to be able to tackle big complex hernias robotically as well. And that's something I'd like to do in the future. I have been laparoscopically, endoscopically, and robotic certified since residency. So it's a little bit about my training background. I did train in a small community hospital. Bartow Regional is about 77 beds, so it's a little smaller than where I trained, but about the same ER visits as well. So I'm very comfortable in a small community hospital and having that kind of personal relationship with my patients and the staff and things like that. So, and I definitely have that good experience here at Bartow. So robotic surgery. Robotic surgery has actually been around longer than a lot of people know. It's actually in the 1980s. They first developed a robot to do brain biopsies. There's a picture of it there on the left-hand side. And then the Da Vinci Xi, which is the current system I use, is on the right side. Obviously, we've come a long way, but Da Vinci robotic surgery first started in 1997, actually. So even that was a very long time ago. So, but we have obviously increased our technology and the things that we can do exponentially since that time. Okay. So why robotics? Why did we develop robotics? The main reason is that it has several benefits. Minimally invasive surgery is always good for patients, but you are limited laparoscopically in terms of what kind of things you can do, especially with hernia repairs. And I'll kind of discuss that in detail, and we can go into more dialogue with the questions as well. But laparoscopically, you kind of are just plugging a hole, where robotically, you're definitively closing the hole and you're patching it and you're doing suturing and you're putting the mesh in areas of the abdominal wall you can't otherwise do laparoscopically. So you could really do big, major surgery with little tiny incisions and have a really quick recovery time and have really good outcomes that way. It's also easy to train staff. I remember when I first came to Bartow, everyone was nervous about having a lot of robotics go on, but really the scrub techs and everybody who assists in surgery, the robot works the same for every surgery we do. The instruments load and unload the same way. It really takes the pressure off of the scrub tech and the bedside assistant. And because I do a lot of troubleshooting myself, but they don't have to assist in holding instruments or holding the camera and all those kind of things that you have to do with laparoscopic surgery. So it's a lot easier to train people. And so even if they're relatively inexperienced, we can still have a really good operative experience. So robotic hernia surgery, I'm going to talk about specifically. The benefits really of doing hernia surgery robotically is that you can do small incisions and you can fix really big hernias that way. It used to be that if you had a big hernia, you'd have to have a big incision and a big long recovery period, and that's not necessarily the case anymore. So it's really allowed us to do big operations, and give people really good fast recoveries and have good outcomes. And in particular, we have better outcomes than laparoscopic surgery. And the more and more data that we collect comparing the two, really, I think eventually laparoscopy will become obsolete in the hernia realm at least. So particularly in this program here at Bartow, we're really trying to develop high volume and high quality measures. I think within the first quarter I was here, and maybe the second quarter, we actually got our robotic center of excellence. So between me and my partner, we did more in a quarter than they did an entire year before we were here. So we're very excited about being able to do that. We do acute care surgery robotically. And then, of course, the procedure I like to do the most is hernia repair. What I'll do right now is I'll kind of just discuss the basics of hernias and kind of basically what I do to repair them robotically. And then after that, we can go into some questions. A hernia is
Dr.
just,
Enders,
yeah,
if I
go
could
ahead.
just, could you explain to everyone on the call exactly what it means to be a center of excellence?
So a center of excellence is basically a national recognition. There are societies, there's hernia societies, robotic societies, there's different societies, that all throughout the country that are nationally recognized that basically kind of give their stamp of approval when they think that an institution has met the stringent requirements that they have. So, for example, to be a stroke center or to be a heart place, you have to have certain cath lab times and certain outcomes. So there are center of excellences for both robotics in general, which is what we have here. There's also a center of excellence for hernias in particular as well. The Hernia Society and other societies contribute to that. So there's a certain volume of cases that you need to do per month. And then you also have to have a certain outcome, wound infections, recurrence rates, rehospitalizations, and also length of stay. So most of my robotic surgeries, whether they're inpatient or elective, very rarely do they stay in the hospital more than 24 hours. And those are the kind of numbers that they look for. So it's just a good indication if you're a patient and you want to get your hernia repaired or you want to get some sort of robotic procedure, if it's at an institution that has the center of excellence, know that they have put in a lot of hard work and have really good outcomes that are patient-centered, to be honest with you. It's all about patient safety and patient satisfaction is what these numbers really equilibrate to. It's less of a financial thing, although it is financially efficient as well, but at least know as the patient that that's the main focus of getting that certification. So you can expect a higher quality of care.
Thank you. And I think I skipped your slides ahead accidentally when I clicked the mic on.
No, don't worry. I basically went through all the slides, and what I was going to do now is just do a quick brief of what a hernia is, and then kind of how it's fixed in kind of general terms. Obviously, there's different ways of fixing hernias, and you talk to another general surgeon, and they may do it differently and have a different approach, and both are right. It depends on their training and their what they feel comfortable with. But basically, a hernia is a hole. The abdominal wall hernia, the abdominal wall has several layers. The main layer we're talking about is called the fascia. The fascia is a very strong, durable layer that kind of envelopes the abdominal wall muscles. So there's two ways to get a hernia. Number one is you have a congenital or a hernia that you're born with. That's usually at the belly button or in the groins. And that is because those are areas where there was no abdominal wall. There's either an umbilical cord there or the groins. There was a canal for the testicles to drop to the scrotum. And those areas fill in with scar tissue after birth. However, some people make weaker scar tissue and then they develop a hernia in that area or a hole in that area. The other type is that someone like me gives you one by doing a surgery on you. So if you're ever cut or something in the abdominal wall, even though it heals back, that scar tissue is only about 70% as strong as it originally was. So there's an inherent weakness there that you can develop a hernia in that area from prior surgery. Whether it's from a congenital or an incisional, it doesn't matter. It's fixed really the same way. The principles are pretty much the same. There's two main things you want to do. One, you want to reduce the hernia and the hernia sac. And two, you want to repair the defect or the hole. Now, there have been different ways of repairing the hole for an umbilical or an abdominal wall hernia. Typically, before robotics and laparoscopy, we'd make an incision over the hole. We'd reduce the sac. We'd place a piece of mesh, usually underneath the muscles, and then we would close the hole on top of the mesh. Now, the disadvantage of doing a surgery like that is because the incisions are bigger, it usually requires at least 6 weeks of no heavy lifting to recover so that the repair can heal adequately. You're also limited in terms of the size of the mesh you can use. It's very hard to make a big space underneath the muscles and use a large piece of mesh and be able to suture it in place. And then the last disadvantage is that the incision is really close to where the repair is. So there's an increased risk of infection because bacteria from the skin have a shorter distance to travel to get to the mesh. And mesh infection, although is rare, is a very big hot topic and a very hard thing to deal with clinically. Robotically, your incisions are distant from where the hernia is. It's typically on the side of the abdomen, very far away from the hernia. They're small incisions about the size of a fingertip. I typically use 3 incisions, one for the camera and one for 2 ports that I basically work with the robot. I have a variety of instruments I can use, from scissors and little graspers that help me reduce the hernia sac. And then what I do is I can make a little cut in the abdominal wall and bring down one of the layers, and I can place the mesh on the inside of the abdomen and cover the mesh with the layer that I create. I can also suture the hole closed with the robot. That's something that is very difficult to do efficiently laparoscopically. So whereas before we would just put a piece of mesh up there and just kind of tack it in place, robotically, I can suture the hole closed and I can place the mesh there. I can suture the mesh in if I feel I wish to do that. And then I can cover the mesh and make a pre-peritoneal repair. I also have the opportunity to make a deeper cut and put the mesh underneath the muscle but above the fascia, which is a retrorectus repair, which is the best place to place a mesh according to the Hernia Society. So, and that's all almost impossible to do laparoscopically. And again, you'd have all the disadvantages of open surgery I just discussed. So you have the benefit of a minimally invasive approach, but you can do a repair that you could normally do only open. So it's kind of the best of both worlds. So that's kind of hernia repair in a nutshell, and the advantages of robotics. Now, if anyone has any questions, I'm an open book.
I am going to take a second to turn the mics on for people. Our first question, though, is when it's time to repair the hernia, this individual is told they have 2, but no process needed until there was pain and discomfort. At this time, I get swelling, but no major pain, and it was 3 years ago.
Yeah, so there's a lot of different ways to clinically approach this. We have a lot of people have different reasons from a surgical standpoint to offer surgery or not offer surgery. There's a lot of components, but there's 2 main components that I look at when I'm assessing a patient. One is whether the patient is a good surgical candidate. They can have a simple surgical problem, but if they have really bad medical problems where the surgery is too high risk for them, well, that kind of would make me not want to do the operation electively, right? But then the second is the feasibility of the operation. If the hernia is very large or very complex, or it may require a specialist to be able to, it may not be an operation that I could do technically from a technical standpoint. Other than that, it's really up to the patient and the physician to have a conversation regarding how bad it bothers them. If the hernia doesn't bother the patient very much, you can observe hernias. However, almost all hernias get bigger with time, and there always is a risk of incarceration. Incarceration is when something gets stuck in the hernia and won't go out. If that's just a piece of fatty tissue, it can be painful, but it's safe. However, if that's a piece of bowel, that can be a surgical emergency. Now, that's very rare that occurs, maybe 1 or 2% of the cases, but it can occur. And when it does, sometimes you need an emergent operation. It's a bigger operation than would originally have been. Sometimes you have to resect bowel, and sometimes you can't use mesh or do a good hernia repair at that operation. When all of that could have been avoided if you just operated on it electively when there weren't any problems. So all that kind of that risk assessment and that discussion happens with the patient. And then I have a very back and forth equal collaboration type relationship with my patients. And I like to educate my patients on everything that all the options they have and the risks. And I kind of put, well, this is what I think we should do, but it's really up to you based on everything we discussed, and we make a decision together. But most hernias, as long as you're not a bad surgical candidate, should probably be repaired.
Excellent. So it just shows the importance of having a good conversation with your physician. Our next question is, are there certain groups that are at higher risk for hernias, say men versus women, age, pregnancy, or something along that lines?
Yes, there's several risk factors for either developing a hernia, or if you have a small hernia, the risk of it getting larger with time. So if you've had multiple pregnancies, anything that increases intra-abdominal pressure will either could predispose you to developing a hernia, or if you have one, will increase the rate that it grows and the risk of incarceration and etc. So smoking is a risk factor because it weakens tissues naturally. Pregnancy and obesity are risk factors because the increased abdominal pressure. If you do a lot of heavy lifting throughout your life, that's a risk factor. In fact, I had an inguinal hernia when I was very young in my 20s, and I was an avid athlete. It got big really quickly because of how much I worked out and how much pressure I exerted onto it. Diabetes is also a risk factor for developing hernias, but it's more of a risk factor of complications involving those hernias. And all of those above mentioned things, especially obesity, diabetes, and smoking, are also risk factors for complications after hernia surgery. So part of the Hernia Center of Excellence recommendations, they do have BMI and A1C recommendations for preoperative assessment and patient selection. And then also obviously tobacco cessation is very important as well. So it's funny because the things that will predispose you to having a hernia are the things that need to be addressed before getting the surgery to ensure you have a good outcome as well. So
You need to live a healthy life. Um, so they've heard that sometimes there's a problem with the mesh. Is it the type of mesh that was being used or the brand? It's been several years, but it was in the news a lot.
yeah, that's Bard. There's a giant lawsuit that's going on from a mesh that was used that we don't utilize anymore. It was utilized a long time ago. However, mesh infections, there can be a technical aspect to it too. Sometimes unavoidable, sometimes avoidable. And then in terms of mesh characteristics, meshes have evolved quite a bit. They are now what's called macroporous, which means the holes in the mesh are very large. And the synthetic material used in the mesh, there's less material involved. So they used to be sheets with very, very little holes. They weren't very porous. They would collect a lot of fluid, and there was a lot of synthetic material to harbor an infection. So all of those qualities made those meshes that were originally used a long time ago more predisposed to becoming infected. The meshes that we use now, it's not very likely they get infected. I think mesh infection is still in the single digits in terms of percentage, but it's not that it doesn't happen. But it's more often that if it does happen, it's because there was some sort of contamination at the time of the surgery. Sometimes if we're doing a surgery that involves an inflammatory process or a bowel resection, even if there's not a spillage of anything and everything was fairly well contained, there still can be an idea that there can be bacteria that can translocate and infect the mesh later on. Now, with that being said, a lot of mesh infections can be managed with antibiotics. But if it's a true mesh infection, a lot of times the mesh does have to be removed. Now, interestingly, there are meshes being developed that are biologic in nature. We've always had biologic meshes and absorbable meshes. Those can be used in contaminated fields and won't get infected, but the body absorbs them with time, and eventually there's a 30% chance you'll get your hernia back. So we've always had to weigh the risk of recurrence versus the risk of infection when we're dealing with, do we use an absorbable mesh or a permanent mesh? Now they're developing a mesh that is absorbable, but does have a lattice work of very thin suture that's permanent. So it's supposed to maintain its integrity like a permanent mesh, but won't get infected the way a permanent mesh would. And so far, the preliminary results are pretty good in terms of the recurrence rate is equal to a permanent mesh and they don't get infected. So hopefully this whole idea of mesh infection will be in the past when we really develop the technology where we don't need permanent mesh anymore. But yeah,
Awesome.
that is something that can happen.
Can you give us an example or kind of give us perspective on what do you mean by a large size hernia? So compare it to a grape or something like that. And then how long is the recovery from a robotic surgery?
So Typically, if I do the entire procedure robotically, it's 10 to 14 days. I just ask people don't lift more than a gallon of milk, but you can do literally anything else you want to do. And in terms of large and small, really anything under 3 centimeters, which would probably be the size of a large, like more of like a golf ball size, would be the upper end of a small hernia. Between that and maybe like a softball would be like a medium hernia. And then something that's like 6 or 7 centimeters or larger, that would be considered a large hernia. So, and typically with hernias that are smaller than 6 centimeters or a softball size, they can be closed primarily and a preperitoneal mesh be used. Larger ones, sometimes they require you to do what's called a component separation, where you cut there's 3 layers of muscles on the outside, on the lateral aspects of your abdomen. You cut the innermost muscle, it's called a transabdominis release, and that loosens it up so you can close the hole without any tension. And that's a little bit more involved, but it can still be done robotically, and the recovery for those are all still the same, 10 to 14 days, no heavy lifting. And that's not a scientific thing. That's just something I use. I have some colleagues that have no lifting restrictions and they have great outcomes. I'm just like, I just feel better if you just take it easy for, 10 to 14 days. It's kind of a physician and patient preference. But because of where the mesh is placed and how the surgery is performed, it's really hard to screw it up as a patient, the repair.
We have a couple of people who have had previous hernia surgeries, and they're asking some various questions, but the gist of it is if they've had a hernia surgery before, and maybe they had to have intestine removed, or they had the mesh in there, and now it's twisting and stuff, what is the safety and the need for a secondary surgery if they're having some issues now?
So I have seen a couple patients that have actually had that, and it just depends on what kind of symptoms they're having, if they have recurrent bowel obstructions. If the mesh is not infected and they're not having bowel obstructions, it's usually safer to try to avoid a reoperation, because a lot of times and a lot of these are laparoscopic repairs, and I don't know this individual's repair or what happened, but sometimes laparoscopic repairs, the mesh is just kind of tacked in there with a little tacker. So it's very easy for those meshes to just kind of get disrupted. And then they get all tangled up in the bowels, and that can be a real mess. Typically, a very large bowel resection is required to explant that mesh. And then patients don't have very much bowel left, and then they have a big hole left over because you have to remove, the hole is still there, and you can't really do a mesh repair again because it's a contaminated field. But that's where these new meshes come in. When you do a procedure like that, you could do a repair, and you could do one of these new meshes that don't get infected and still have good recurrence rates. But typically a specialist who's well-versed in dealing with these kind of complicated reoperations would be someone I would seek out, but it's not impossible. It just depends on how it's bothering them and the complexity of their case.
We have a couple of questions also that kind of link into like a hiatal hernia and maybe some acid reflux. Does
Sure.
the robotics work well with this? And is there any limitations if someone's age that maybe they shouldn't have these procedures?
So age is just a number.
Amen.
And when I deal with, whether I'm doing a colonoscopy, whether I'm doing a big surgery, the only thing that I consider is the patient's physiologic age. So I'm sure we've all met people that are in their 40s and 50s, and man, if they got a cold, they're on death's door, right? Because they're very sick people. They have poorly controlled diabetes. Maybe they're severely obese. Maybe they're really bad lungs. Or maybe they have a terminal illness that their life expectancy has been shortened. Those individuals, it doesn't matter what age they are, yes, you should avoid a major elective operation because the risk is just too great. However, just because you're 80 years old, if you have no medical problems, you're very active, maybe you bike or walk every day or swim, you're completely independent, you don't take any medications, you can do very large operations electively on patients like that, and they do better than young people actually, because they're pretty disciplined because they already take care of themselves very well. So they behave and eat and do all the things you want them to do anyway. So they can have very, very good outcomes. In terms of hiatal hernias specifically, it's perfect for the robot because The hiatal hernia dissection, to do a true dissection, you really want to mobilize the esophagus well up into the chest. That's very difficult to do laparoscopically with good visualization. The robot is actually initially designed to do intrathoracic surgery and work in small spaces and have great visualization. So it's a perfect operation to be able to do that. And you can also suture close the hiatal hernia when you're doing the repair. And it's just easier to see and mobilize things and move. It just makes everything so much better and easier. Now, a really well-versed laparoscopic surgeon can do an amazing hiatal hernia repair laparoscopically. In fact, many do, and they're not doing robotics simply because they're so good laparoscopically. But the robot offers advantages for a surgeon who maybe doesn't have as much experience as that prior mentioned surgeon who wants to do hiatal hernias and still have as good outcomes. So it basically expands the horizon ergonomically and technically so that the learning curve is actually easier for robotics than it is from laparoscopic surgery. So it's easier for us to develop the skills and have good outcomes, even if we don't have 20 years of experience per se. So that it always has an advantage from that standpoint.
We have a question about we have drug eluting stents. Do you think they'll ever come up with the mesh that has some drug that gets emitted from it also after it's in place?
I don't think there's a need for that. Typically the thing about the mesh is you want the mesh to incorporate into the body. Prosthetic meshes, they inherently have an inflammatory response as the body sees it as a foreign object and it tries to reject it. And that inflammatory process is why permanent meshes, we're trying to develop new meshes that maybe have less of a reaction like that. So they don't necessarily have drugs, but the new meshes that I was discussing that are biologic in nature, they do have growth factors that attract cells that come and promote collagen and healing and help minimize the negative inflammatory response and promote more of a positive pro-healing response to help the mesh incorporate better. So those are things that are kind of cutting edge, but not necessarily like a drug. But I guess if that answers the question.
And then if this process is considered elective, does insurance pay or is this going to be all out of pocket?
Oh, yeah. So elective surgery it doesn't mean not indicated surgery. Elective means it's not an emergency. That's all. That's all it means. So in terms of getting insurance to cover hernia, most insurances cover all inguinal and umbilical and incisional hernias. There's usually not a problem getting insurance to cover.
We have two more questions that are on the list, and I've kind of held off on them. So if people type them in, this is why. They're more specific to their needs, and I don't want them on the recording. So I'm going to stop the recording now, and then I will ask you the next two questions.
Sure.
All right. So see, I wasn't ignoring you. I was trying to be